day on a early Sunday morning. I hope everyone's staying safe. I know two of your leaders are in Texas and, you know, dealing with everything that's going on in Texas, and just hoping that everyone's staying safe with everything going on. So yes, so I am an allergy and asthma and immunology specialist. I treat both adults and kids, and so, you know, I like starting off with this quote: "The days are long, but the years are short." And that's just so true in life in general. And so I say that only to remind everyone to enjoy every moment, even when, you know, you're just focusing on the future, focusing on getting into medical school, focusing on, you know, just really what your future goals are. I think a lot of times we miss out on what's happening in our lives right now. And even though right now what's happening might be scary, and might also, there's lots of things, you know, like COVID and weather issues and all of those kind of things, but there's still a lot to be grateful for. And I think it's just really, really important to remember that. So, and especially in this journey of getting into medicine, getting into medical school, all of these things, there's just going to be a lot of moments where, you know, you really need to stop and think about all the positive things that are happening, and not just focus on the future goals. And so, you know, I think some of you might have joined me for my first presentation. And so there might be a little bit of redundancy where I just introduce myself, tell you a little bit about my journey. And then we're going to go through 2 case studies. I was going to do 3, but there's actually just so much to discuss in each case that even, you know, we're not even getting really deep into every condition, even with these 2 case studies. So I know there's going to be a lot of questions, and you guys can feel free to ask me anything at the end of the presentation. So getting started. So my journey is, you know, I went to undergrad for 4 years at the University of Michigan. I majored in biopsychology and religion. Biopsych is just a very important, very popular major at the University of Michigan, where it's a combination of, you know, how the brain function and kind of causes psychological disturbances. And then I also did religion just to kind of get a broadened picture and of something else besides just focusing on sciences. And so that was kind of my undergrad experience. Medical school, 4 years, I went to Michigan State University, the College of Human Medicine. There's an MD program, which is the College of Human Medicine, and then there's also a DO program at Michigan State. And then I did my residency for 4 years at Rush University Medical Center in Chicago, which is just an awesome place. And if anyone's considering it and has any questions about it, please let me know. I absolutely loved my experience there, and I can talk to you about it and tell you why I loved it. And then I did fellowship for 2 years at Downstate Medical Center in New York City, so it's in Brooklyn, and my fellowship was obviously in allergy and asthma. So a lot of years, but again, you know, the journey's long, but you have to enjoy the present moment and what's happening in every step of the way. And so, you know, choosing your path, it's really important to understand what you're getting into. So, you know, medicine, going through and becoming a doctor, as you saw, are a lot of years, and figuring out where you want to be at the end is it's hard, you know, and so because there's so many options, there's so many different fields that you can practice in. Do you want to just do pediatrics? Do you want to just do adults? Do you want to do a combination of both? Which, you know, how do you want to practice medicine? And so I think the best way to figure that out is by shadowing. And that's why I think it's so great that you have this opportunity with socially distanced shadowers, just to get a little bit of a picture of what the different fields are, especially right now with COVID, not being able to physically shadow doctors, I think, you know, is probably doesn't feel good to a lot of you, but this is a great way just to get like a little picture into what different fields of medicine do. And so I'm really glad that you guys are getting this opportunity. And so in every specialty, it's important to remember that there's a lot of different ways to practice. Decide that you want to be an allergist. The way that I'm practicing allergy, I mostly am have had experience in private practice, mixed with a little bit of academic, and then now I'm doing a lot of telemedicine. And so, you know, there's so many different ways to practice. There's so many different combinations. So you can do only academic, you can do only private practice, you could do only telemedicine actually, or you can do a combination of any of those. And so it's just important to remember that in medicine, that there's just so many different opportunities available. And then even within that specialty, you can focus on one area, like, you know, within the specialty of allergy, asthma, and immunology, I could just focus on asthma if I really wanted to. And if I wanted to focus all my research in asthma, if I wanted to have, you know, just be very much focused in asthma, I could just have an asthma clinic. So within any specialty, you can also just even focus on just one condition within that specialty. So it's just really cool to see how many different ways you can practice medicine, and it's just important to remember that as you go along. And so I did something called Medpeats. So what is Medpeats? Medpeats is where you can get trained in both internal medicine and pediatrics. So usually internal medicine is its own residency, pediatrics is its own residency, but with Medpeats, as opposed to 3 years of each, you actually do 4 years in a combination. And you get trained in seeing adults, which is what internal medicine is, so 18 and over, and also pediatrics, which is from birth to 18 years of age. And you can take boards in both internal medicine and pediatrics, and then you can subspecialize in any specialty within either internal medicine or pediatrics. So for me, it was the best. You know, I'm a Libra, so people say that Libras are very indecisive, and I could say that I really am, and I really like balance. And so with Medpeats, I felt like I had a good balance. I felt like I was going to be able to see kids, I was going to be able to see adults, and I didn't have to pick from one or the other. And so, you know, there are physicians that practice Medpeats generally, and so they will see adults and kids in a general practice, similar to maybe what a family practitioner does. But the difference between family practice and Medpeats is that with family practice, you may also do some obstetrics, whereas with Medpeats, you're not going to do any obstetrics. You're not going to be delivering babies. And it's not really as surgical. And so that's a difference. The other difference between family medicine and Medpeats is that you may also, you can subspecialize in more fields with Medpeats, whereas with family medicine, there aren't as many subspecialty options. So those are just some differences, some basic differences. So if you guys have any questions about that, we can talk about that. And then what's allergy and immunology? So with allergy and immunology, again, I kind of knew that I wanted to do this field of medicine pretty early on. And that's also why I picked Medpeats, because when you go into allergy and immunology, you actually do see both age groups. So you see adults and kids. And I like allergy and immunology because you really do treat patients from head to toe. And I'll kind of review overall like the different kind of cases that we see, and then I'll particularly go into 2 specific patient cases. But you know, we see skin conditions, conditions that affect the eyes, the nose, the lungs, even the GI tract. So we really, and the immune system. So we really see different conditions spanning throughout the entire body. And that's really why I love allergy so much, because I really feel like there's no way for me to get bored. And then again, you know, you can practice outpatient only or academic or a combination. So a lot of people like allergy and immunology because they call it the dermatology of like kind of internal medicine pediatric space, because it really, you're not going to deal with a lot of emergencies. Any emergency within the allergy immunology space is really going to go to the emergency room, and you're not going to get called in at night or anything like that. So it's a nice field for in that way, where there is some good work-life balance, and so that's another great, you know, one of my patients, respiratory tract infections, which he feels are present year round, but generally flare up in the fall and winter. So he often travels. So his name is Joseph. I changed his name for this presentation, but Joseph often travels for work and states that staying in a hotel or cleaning make his symptoms worse, especially if it is dusty. He's frequently on antibiotics to treat his upper respiratory tract infections during the fall and winter time. And just as a caveat, those upper respiratory tract infections that he keeps getting treated for, he's mostly going to an urgent care center or even sometimes the emergency room to get treated. And then Joseph has tried the following for the past 3 months with his primary care doctor, who put him on some nasal saline rinses at home, a steroid nasal spray, which he takes on and off, and then an over-the-counter, so OTC stands for over-the-counter, antihistamine, oral antihistamine. And then Joseph's prolonged uncontrolled symptoms like congestion and conjunctivitis. So congestion is, feeling congested in your nose, so feeling like blocked in your nose. And then conjunctivitis means like the conjunctiva of the eye is inflamed. So conjunctivitis, itis means inflammation. So he has conjunctivitis, inflammation of his eyes. And both of those really contribute to sleep issues. He feels like he doesn't get good sleep and is constantly waking up in the middle of the night, or just doesn't feel like he gets restful sleep, really. And Joseph has never been tested for allergies, so this is his first time seeing an allergist. And on exam, his turbinates, which are the tissues inside of his nose, are pale, so they're boggy, which means that they look congested, they look bigger than they should, and then they're also a little bit bluish in color. And the way that you look at the turbinates is you literally just put you can use the same kind of tool that you use to look in the ears, the otoscope, to look into the nose with the light and look to see the tissues inside the nose. So it's a very superficial exam, but it's very obvious when people have these kind of pale, boggy, bluish turbinates. And his eyes are watery and injected. So when we say that eyes are injected, that means that they're that you can see like redness, and you can see the essentially that the conjunctiva is red. So the white space has some redness to it. And then an office skin prick test. So that's what this picture is over here. So skin prick testing is a test that we do in the office. Proficient at it and well trained in kind of evaluating what a positive test looks like, and how to place the skin prick testing well. And so you can see here, hopefully, that that there are like big bubbles, basically like inflammation, irritation, redness in several areas. So this patient actually has a bunch of positive tests. So this isn't Joseph's arms, but this is another patient of mine who has multiple positives to a bunch of trees, dust mites, cockroaches, cats, and dogs. So this person's very allergic. Our patient that we're talking about today had skin prick testing, which was positive to grasses and dust mites. So his skin prick test would be more would have looked a little bit different. He would have had all of these positives. So essentially with skin prick testing, we put a little bit of what we call the serum, which the serum is something that you buy from, you know, a medical supplier, and each serum is different. So as an allergist, we get like 70 different serums that we want to test for. So things like cat, dog, trees, weeds, grasses, molds, cockroaches. So all of those things are turned into a serum, and it's the proteins that people are allergic to within those different allergens that are put into those serums. So when we have that serum, we place it on the skin and then we prick it into the top layer of the skin. So we're not putting it deep into the person's body. It's literally just pricking the top layer of the skin. And when we prick the top layer of the skin with these protein serums, then it causes an allergic reaction for people that are allergic, and it releases histamine, or it causes the mast cells in the skin to release histamine, which is the key component of allergic reactions. And that release of histamine causes this this inflammation and irritation and bump essentially to form. And the size of the bump is measured, and the reaction around, so it's called a wheal and flare reaction. So the wheal is that bump, and the flare is the redness around that bump. And so we measure that wheal and flare reaction, and we compare it to control, a control and a positive. So a control is going to be just saline, so plain water. And then we also use histamine, which again is the thing that everyone reacts to. And we prick both of those things into the skin to see what a patient's reactions are going to be just to the control or just to histamine. And so it's important to have those controls on there, the positive and negative. So the negative should be the saline. Water should not give people an allergic reaction, right? And so we compare the water reaction to the histamine reaction to all the other reactions. So if someone is very sensitive, if their skin is just sensitive to even the pricking sensation, they might be somebody that's dermatographic. And when you're dermatographic, that means that your skin is just super sensitive, and even just that pricking sensation will cause somebody to have a little bit of a wheal reaction. So they'll get a little bit of a bump just from pinching their skin with the prick. And so in that case, everything's going to look positive, including the negative control, including that water, that saline control that we put on there. And so in that situation, we're not going to tell somebody that they're allergic to everything. What's really happening is that their skin is super sensitive, and the skin prick testing isn't the right kind of testing for them, because we're just not going to get accurate results. And so that's why it's really important to have a positive and negative control to make sure that we're weeding out those people that just have super sensitive skin. For those patients, skin prick testing is not right, and we would actually do blood testing on those patients and look for Ige antibodies to the different allergens. So I'm sorry if this is a lot of information. It's like I said, that every case, there's so much to talk about. And I know everyone's like knowledge base is different. And so hopefully hopefully it's not too much. But you know, in general, up to 40% of Americans suffer from environmental allergens. And environmental allergies, we're not talking about food allergies, even though food allergies are tested in a similar way. We can do skin prick testing or blood testing for food allergens. But today we're really talking about environmental allergens that cause allergies of the eyes and nose. And so environmental allergens are triggered by things like trees, grass, weeds, dust mite, cockroach, cat, dog, or mold. And the symptoms are similar to what our patient Joseph had. So runny nose, itchy eyes, congestion, fatigue because of poor sleep, rashes can oftentimes occur. So people can get eczema because of their environmental allergies. They can get coughing or wheezing. So it can also cause allergic asthma when someone's allergic to environmental triggers. So the diagnosis, again, is made by skin prick testing, which we've talked about, and then or a blood IgE test. So IgE antibodies are what cause people to be allergic. So people who have IgE antibodies to specific proteins, like what we were talking about, you know, like a dog protein or a cat protein or a tree protein, the people who are allergic, like me, I have a lot of allergies. I have IgE antibodies to those particular proteins, so that when my body is exposed to those allergens, my mast cells will get triggered by my IgE antibodies, recognizing those proteins. And when that IgE recognizes that protein, it causes kind of a connection, and that connection then results in mast cells being triggered, and mast cells then release mostly, like the main thing that they release is histamine, but then they release a bunch of other chemicals that cause inflammation and irritation in our body, which result in all of these symptoms like itchy eyes, runny nose, congestion, rashes, coughing, wheezing. So essentially it just causes this inflammatory reaction all over our body. But with environmental allergies, everyone has different symptoms depending on which part of their body reacts more to that release. So for some people, they really just have irritation of their eyes. So they're really just going to have that itchy, watery, red eye. For other people, they're going to have itchy eyes and runny nose. So it's really that the mast cells are triggered mostly in the eyes or mostly in the nose. And then for some people, they also have, their skin is super reactive, and their skin mast cells are triggered by environmental exposures. And then for some people, they're in their airways, they get triggered, and that releases the mast cells in their airways and causes asthma symptoms. And so, you know, somebody like for me, for example, I have allergic rhinitis, which is, you know, inflammation of my nose. I have allergic conjunctivitis, which is inflammation of my eyes. I have eczema, which is irritation of my skin. And I also get asthma when I'm exposed to a trigger. And, you know, mostly that happens when I'm exposed to cats. But sometimes when I'm in a different environment, like a different country or warmer climates and it's allergy season, meaning like pollen allergy season, then I might also get triggered. And so that's really what, you know, led me to want to become an allergist, because I truly understand how debilitating allergies can be. So a lot of people, including doctors, don't really understand how debilitating allergies can be. And because it's not life-threatening, it's more of a quality of life issue. I think people underestimate how terrible allergies can be. And I say that with a caveat, asthma can be life-threatening. And so allergies can be life-threatening if you have allergic asthma that's triggered by your allergies. And so and then also just the quality of life issue. If you constantly feel like you have a cold, if you can't keep your eyes open because they're always itchy and irritated, you're not gonna, again, sleep well, you're not gonna be able to concentrate at work or at school. So allergies actually account for a lot of missed work days, a lot of missed school days. And so again, there's a lot of life that's missed because of allergies, and just the overall general just quality of life issues that are so important to think about in any field of medicine. Also, you know, it can cause anxiety, depression. Almost any medical condition can cause anxiety and depression, but even allergies can cause anxiety and depression for people who have really bad eczema, for example. It's something that they deal with that's physically outwardly apparent right now with COVID. If you know you're sneezing and coughing, people are worried that you might have COVID. So a lot of my allergic patients are they just really want to get their allergies under control, because not only are people worried that they're sick, but also they're worried that they're sick, and they oftentimes can't tell, is this just my allergies or am I sick with something else like COVID? And so there's just a lot of different things that you have to think about, even when you can't see that a condition is life-threatening. You have to see all the different other factors that are affected by any medical condition. And so allergies really affect people in a bigger way than a lot of people know. And so, why is it important to know what you're allergic to? So why is it important for people who are really suffering from any of these symptoms to find out if they're allergic to something? Well, there's a lot of different environmental measures that you can take. For example, if someone's allergic to their pet, it's really hard to tell somebody to get rid of their pet. And I have, with years of experience, I've realized that you should never tell somebody to get rid of their pet, because they will never come back to you. But you can give them recommendations on things that they can do in their home. And then also it can guide immunotherapy treatment. So if someone's allergic to their pet, they can get immunotherapy, allergy immunotherapy treatment. And we'll talk about that next or in a little bit. And so, so finding out what you're allergic to can really help. If you're allergic to dust, there's things that you can do. If you're allergic to, seasonal triggers like pollen, there's different environmental measures that you can take. So for example, for dust, you can use dust mite covers. So dust mite covers are really, in my opinion, most important for your pillows. And how dust mite covers work is that when you're allergic to dust mites, you're allergic not to the dust mite itself. So dust mites are these like tiny little mites that we can't see with the human eye, and they live off of the flaking of our skin. So actually dust mites are mostly found in our bedding, and we're not allergic to the dust mite itself, we're allergic to their droppings. So so again, dust mites live off of the flaking of our skin, which is really gross. And then we're not allergic to the dust mite, but we're actually allergic to their droppings. So how can you get rid of their droppings, and how can you ensure that you're not sleeping with a bunch of dust mite poop? You need to wash your sheets in hot water at least once a week. You can use the dust mite covers. And what dust mite covers do is they prevent from the dust mites from going into the pillow and pooping inside the pillow. And so essentially it's keeping the inside of your pillow from becoming just a big thing of dust mite poop. And so that's really where I think the most important thing is to keep clean. I mean, they make dust mite covers for every part of your bed, but it can get really expensive. And so I think the most important thing for people that, can't afford to cover their entire bed with dust mite covers is to get dust mite covers for their pillow, make sure their pillows aren't super old. So things like that. For cat and dog dander, things like air purifiers are really helpful. I also recommend that patients don't sleep with their pet in their room, because most of the time when we're spending time in our homes, we're spending time in our bedroom. We should be sleeping, 7 to 8 hours ideally. And so those 7 to 8 hours, if you're in a space that has your allergen all over, you're not going to do well. You're going to have more symptoms. And one of the things that I didn't mention with the skin prick testing that's super important is that, once we kind of prick your skin with those allergen proteins, then we wait 15 minutes for the mast cells to do their thing, for the mast cells to trigger histamine release. And the longer that allergen stays on your skin, the bigger the reaction gets over time. And so, so that's the important thing to remember with allergies, is that if you're in a space with your allergen and you're getting more and more exposed to that, the inside of your nose is getting, a little bit of that, or more and more of that protein in your nose, then your body is releasing more and more of that histamine. And so that's why it's really important to control the amount of exposure that you have to your allergen. And so I always tell patients to make sure that their bedroom is their safe space, and make sure that your pet is not allowed in your bed. That really, really helps people at least mitigate some of their symptoms. And then And so going back to Joseph, so what did I do with Joseph? I asked that he continue to use his nasal steroid spray and continue to use it consistently. So one of the things, so nasal steroid spray is a very good treatment for nasal allergies. And the way that that works is steroids reduce the inflammation they reduce inflammation, right? Steroids are an anti-inflammatory. And so using any anti-inflammatory medication takes time to work. So the way that I explain it to patients is that if you get, like if you have a scratch on your hand and it causes like swelling and inflammation, that swelling and inflammation won't go away, you know, the next day. It takes time for any kind of swelling to go away, even if you're using a steroid cream. And that's just because inflammation just takes time to kind of resolve. And so that's the same thing inside of your nose. You can't see the inflammation, but you can feel it by all of that kind of congestion, irritation, causing the runny nose and causing that you know, postnasal drip and all of those other symptoms. And so the nasal steroid spray, you really need to use consistently. You can't come on and off of it, which is oftentimes the issue with nasal steroid sprays. They made them over the counter probably 3-4 years ago. And I think that that was not a good idea because people just do not use medications in the right way. Sometimes they overuse them, sometimes they underuse them. And so it, especially with steroid nasal sprays, because overusing steroid nasal sprays can be dangerous. I just think that, I don't know, I don't think that it was a good idea to make it over the counter. And then, so again, so you know, he wasn't using it every day. So I told him to use it daily and we would see how he did after like, you know, 3 to 4 weeks, because that's usually how long it takes for people to notice a clinical benefit from using their nasal steroid spray daily. And then I also started him on an antihistamine nasal spray. So that an antihistamine nasal spray is not over the counter. You can only get it with a prescription, and it's basically what it says it is. So it blocks the histamine from getting released, and it's a nasal spray. So it's working locally inside of your nose to get rid of that histamine that causes the inflammation. So doing the combination of a steroid nasal spray and an antihistamine nasal spray, I find works very, very well. And then I continued him on his daily antihistamine pill. So again, antihistamines, there's oral antihistamines, and then there's nasal antihistamines, and there's actually also ocular antihistamines. So there's also antihistamines that we can use for the eyes. And I didn't mention it here, but I started him on some eye drops too with an antihistamine in it to help with his eye symptoms. And then we talked about environmental control measures for dust mites, but because he travels, he has, you know, limited control over what the pillows look like in the hotels. But for some of my patients, I tell them to bring their own pillow when they're traveling to see if that helps. And then at 4 weeks, Joseph came back and he said he was only feeling slightly better, and he felt frustrated because he didn't like using so many medications, and he wanted to discuss if there were any long-term treatment options that he could use. So I talked to him about allergy shots. So allergy shots are one way. They're also called subcutaneous immunotherapy to treat allergies. So I'm going to talk a little bit more about allergy shots in a second. So I talked to him about allergy shots. He didn't think that that was an option for him because with allergy shots, you have to come in weekly for the first 6 to 9 months, and then it goes to monthly treatment. So, you know, coming in weekly for somebody that has to travel for work doesn't work. And then since he feels like his symptoms are kind of persistent, and year round, even though he was allergic to grass and dust mites, I started him on something called Odactra, which is a sublingual immunotherapy treatment. It's a tablet that you put underneath the tongue, and that treats dust mite allergies. And so what is immunotherapy? So immunotherapy is a way to desensitize your body to the things that you're allergic to. So you don't desensitize somebody to allergens that they're not allergic to. That's why testing is so important. You find out what the person's allergic to, and then you can create immunotherapy specific for that patient. It essentially, the desensitization alters the immune response from a Th2 or allergic response to a Th1, which is a non-allergic response. So remember, allergies are essentially the body's abnormal response to something that we shouldn't be responding to. So we shouldn't, like when you are, tree pollen, for example, shouldn't cause our body to get inflamed, but for somebody that's allergic, they produce that IgE, they have that IgE antibody that recognizes tree pollen and thinks that it's something foreign and thinks that it's something that the body should react against. And so we're trying to change that, that Th2, which is histamine releasing, to Th1, which is non-histamine releasing kind of immune response. So allergy immunotherapy is not a cure, but it will reduce symptoms and the use of medications. And for some people, even though it's technically not a cure, it's not going to make you completely into a non-allergic person. It really feels like it is a cure for people that are on allergy immunotherapy. They really feel like, oh my God, now I can be around a cat or a dog, or I can be outside during pollen season and I'm not reacting. So for some people, it really does feel like a cure, even though technically, unfortunately, we can't predict. So let me go into some details. So essentially, the patients that benefit are patients that have allergic rhinitis or allergies of their nose, allergic conjunctivitis or allergies of their eyes, or allergic asthma, which is allergies of the airways. And then also atopic dermatitis, which is allergies of the skin, or eczema, may also respond to allergy shots, but only if we can really see a clear indication that their allergies really are triggered by their allergen, like a cat. Every time they're around their cat, their eczema starts acting up. If they're not around their cat, their eczema generally does well. So in those cases, the eczema should be responsive to immunotherapy. And then clinical studies show that patients with both asthma and allergic rhinitis are probably the best patient because they see definitely the most benefit from getting allergy shots. And then for children, it can actually prevent the progression of allergic disease from just having allergies of the nose to asthma. So, the disease progression from childhood allergic disease to later on is usually you start with allergies of the nose and then it progresses into asthma. But, a lot of kids will just start having asthma right off the bat too. But for those kids that really are only presenting with allergic rhinitis, in order to prevent them from progressing to also having allergies of their airways or asthma, then using allergy immunotherapy early on has been shown to reduce their risk of progression to asthma. And so with allergy shots or subcutaneous immunotherapy, they're done weekly in the office for the first 6 to 9 months, and then it goes to monthly treatment. And, the thing with the weekly for 6 to 9 months is that the person has to be very, they have to be very compliant with that schedule. So if they miss a week, then we have to, push them back. There's a whole different way that we do the dosing regimen for allergy shots. So if they miss 2 weeks, we have to push them even further back. And the whole thing is that with allergy shots, you're slowly building up the amount of allergen that you put into the serum. So we create a special formula for each person. So for example, if I wanted to put Joseph on allergy shots, I would put grass and dust mite. I would make a grass vial and a dust mite vial. Without getting into the details, there's certain things that you can't mix together. So if someone's allergic to grass, trees, cockroaches, dust mites, cats, dogs, if you put cat allergen in with tree allergen, the way that the cat and tree allergen work, if you put them into a bottle together, the cat allergen might destroy the tree pollen allergen. So there's things that researchers have figured out in over the years as to which things we can mix together and which things need to stay separate. So for the most part, if someone's a very allergic person, they would I would make 4 different vials for them, and each vial would contain the different allergens that they're allergic to. And so that person would technically get 4 shots every single week for 6 to 9 months, and then monthly for a total of 3 to 5 years. And we say 3 to 5 years because that's where we know that people get the most benefit from their allergy shots. Now, if someone stops after 2 years, does that mean that they don't get any benefit? No, that's not true, but their potential for lasting benefit is likely not as good. And even for those people that are on shots for 3 to 5 years, once they stop that monthly shot, for some people, they do really well and they're good for another like 5 to 10 years. But for other people, they really need that monthly kind of reminder to their immune system. And so stopping allergy shots, they don't do well. And, 3 to 4 months later, they start feeling their symptoms again. So unfortunately, we can't really predict which patients are going to respond well to discontinuation of immunotherapy and which patients aren't. So some people, if they've had a lot of like really good benefit from allergy shots and they get used to kind of coming into the office, they don't want to stop, and they're too nervous and scared to stop. And so they would rather just continue to get allergy shots. Because unfortunately, if you do stop allergy shots and it's been longer than, technically longer than like 6 months or even short, like even 4 to 6 months, then we have to start them again with that weekly process of building up to get them back into that monthly phase. So it's annoying, but we have to keep people safe. And if we don't do it that way, then people can react to the allergy shots. So that's another aspect of allergy shots. They're done in the office weekly. You get, 1 to 4 shots, depending on how many allergens you're allergic to. And then you have to sit in the office for 30 minutes after you get your shot. And the reason that we have the person sit in the office for 30 minutes is because because we're injecting things that you're allergic to, you could have a reaction to the shot. And that reaction could be as severe as anaphylaxis. So unfortunately, I've had to treat anaphylaxis in my office multiple times because of patients who have had reactions to their shots. It's very rare, but if you have 100 patients coming into shots every week, you are going to have somebody react here and there. But, using epinephrine quickly and monitoring the patient and, treating them quickly is the most important thing. The times that I've had the worst reactions is when someone refuses to wait for the 30 minutes. They leave my office. I live in New York City. They decide to go into the subway. They get down the subway steps and they start reacting. And then they try to run back to my office to get treated. Those are the people with the most severe reaction because there's a delay in the time from when they start reacting to when I can inject them with epinephrine. So those are the scariest reactions. And, if I treat it early, I don't have to call 911, but if someone's really reacting and we end up waiting too long, then I do have to call 911 and the person has to go to the hospital. So, sorry, let me just have this pop up that I can't get rid of. Okay, and then, oops, sorry. And then there's also sublingual drops. So sublingual immunotherapy, sorry. And those come in drops or in tablets. And so allergy tablets are not dosed up. They're actually the same dose. So they've been researched. They're like tiny little tablets that actually dissolve underneath your tongue. And it's the same dose that's started. And you also take that. And actually with the allergy tablets, you take it daily. So, and that's also for 3 to 5 years. And in the US, the FDA has approved 3 different tablets. One is called Nycdoctor, which is a dust mite tablet. Then there's ragweed tablet. Then there's a grass tablet. And in Canada, they just recently approved a tree tablet. And I'm hoping that, you know, there'll be other tablets that come out. The good thing about tablets, especially right now with COVID and people not wanting to come into a clinic space on a weekly basis, is that you can do this treatment at home. And it's just easier. Unfortunately, you can only be on one tablet at a time, according to the FDA, although in other countries, they do use multiple tablets. The way that the studies were done, the FDA just didn't feel comfortable approving them in the US for multiple tablets to be used at the same time. And so unfortunately in the US, we can only use one at a time. But for Joseph, for example, because he's allergic to dust mite and grass, I decided that dust mite would be the better treatment option for him, because dust mite is a year-round allergen. And if we get rid of that year-round allergen, studies show that your seasonal allergies will be better too, because you're getting rid of that underlying inflammation that the dust mite is causing, so that when you're exposed to another allergen, your symptoms just don't feel as bad. And then there's allergy drops, which some doctors use, but unfortunately allergy drops, for me particularly, I don't like them because there's mixed data on the dosing, on whether or not they're effective at the doses that we can give them at, and they're not FDA regulated. So there isn't an FDA regulated version of allergy drops, unfortunately, because of the mixed data. And so I don't believe in allergy drops as much. But there are certain allergists using them, and they feel that it works for their patients. So, but you know, because they're not FDA regulated, insurance doesn't usually cover them. And so they're an out-of-pocket kind of treatment also. So you have to have money in order to get them. So that was, you know, a general overview on allergies of the eyes and nose and environmental allergies. There's a lot of like nuances still within that, you know, condition, but that was a general overview of one type of patient that I might see in my clinic. And then I know, I think this session is only supposed to be an hour and we only have 10 more minutes left. So that took a lot longer than I thought it would, but so, you know, very quickly, I'm just going to go through this case with asthma, but it's, you know, asthma is a huge topic. So I can go through it, or we can just stop for questions. What do you guys think?
So if you want to go over the hour, you are totally fine. We will stay here. It's really up to you how like long you want the session to run.
Okay. Well, I mean, like I said, this could probably take another half hour at least, but so I'll quickly go through it and I'll try to stick to maybe just doing another 15 minutes. But we can always, you know, I think I'm going to be doing these on a monthly basis maybe. And so I can always do just asthma next time. And so, but I'll quickly go over it since I've already kind of put it out here. So, and I'll just go through like the key highlights. So 12-year-old patient comes in with her mom for evaluation of uncontrolled asthma. The patient's been coughing and wheezing daily. Symptoms are worse at night and keep her up. She's using Albuterol, her Albuterol inhaler, which is her rescue treatment, about 4 to 5 times per day. She was put on Flovent, which is an inhaled steroid for her asthma in the hospital, which she uses twice a day for the past, and I didn't mention, but that she's only been on that for the past like 2 months. And she's been to the ER 3 times this past year since moving to a shelter. And she's been hospitalized once, but she's never been intubated. So on physical exam, her lungs, she has mild expiratory wheezes, heard kind of all throughout. And mom states that the patient just used her Albuterol inhaler 10 minutes ago. Her nasal turbinates also are pale and boggy and blue in color. So now we know kind of what that might mean. And social history, she lives with her mom who lost her job, unfortunately, in the last year and was forced to move into a shelter system. The shelter, according to the mom, is unclean and she's noticed mice and cockroaches. And unfortunately, this is not an uncommon scenario for me in New York, and it really, really breaks my heart. And because of her uncontrolled asthma, this little girl has frequently missed school. And then, so what we did in the office, so I'll say this with a caveat because, you know, normally if a patient, so I shouldn't have put the in-office testing right now because I wouldn't do skin prick testing on a patient that has uncontrolled asthma. So I didn't look through this case as well as I should have, but I wouldn't normally do skin prick testing right away. I would wait until the asthma is better controlled because although skin prick testing is generally safe, it can cause a reaction. And so for somebody that doesn't have controlled asthma, I would probably actually do a blood test and look for Ige antibodies to allergens as opposed to doing in-office skin prick testing. So let's pretend I didn't do in-office, but I actually sent her for blood testing and we found that she was allergic to dust mites, cockroach, and mice. And so, you know, asthma in general, here's an asthmatic airway and here's a non-asthmatic airway. So asthma has two different general components, okay? And one is that the airways, so all airways have muscle around them, okay? That's what these kind of things are. It's muscle around the airway, and that's the muscle relaxed, and this is the muscle tightening. So in an asthmatic airway, you have environmental triggers or, you know, viral triggers or cold air can cause the muscles to tighten more easily in somebody with asthma, okay? And then in addition, for this little girl, we definitely know she also has some inflammation in her airway. So the second component of asthma is inflammation, and that inflammation can be either allergic or non-allergic. And so, but what inflammation does is it causes the airway lining to be swollen and produce excess mucus. And so you can see that this is the airway that you'd rather breathe in and out of and get oxygen into your body because the caliber of the airway is a lot bigger, right? Here, you have a tiny little space to breathe out of, which is not good and doesn't allow as much oxygen into your body. And so over time, obviously that causes shortness of breath, irritation, coughing. And so, you know, wheezing is a symptom of asthma, and that's basically a high-pitched whistling sound that you get upon exhalation. And so you're gonna hear wheezing on the exam. However, just like in this little girl where I heard like scattered wheezing, depending on when the person's taken their asthma medications, depending on if, you know, they've just been exposed to their trigger or they're not exposed to their trigger, when they come into the office, they might have a totally normal physical exam. That does not mean that their asthma is controlled. And that's why history is so important with our patients and is one of the most important things when we're seeing a patient in most every single condition. It's the ability of figuring out what's been going on with the patient, not just right now, but over time and over the last several months. And especially in asthma, that's very important. One thing that is really interesting with asthma is that most of the symptoms are worse at night. So asthma, for some reason, has a circadian rhythm. So symptoms will be worse at night. They'll complain, you know, the patient might get so used to coughing and wheezing and not sleeping well at night that they might not be able to say, you know, my little 12-year-old patient might not say, oh yeah, I'm waking up at night, but her mom will know that she's waking up at night. So a lot of times people will wake up coughing and wheezing and just kind of fall back asleep and not even know that they're doing that. But the person living with the asthmatic person will say, yeah, they're coughing all night. They're wheezing all night. I hear them in the other room. So that's just one important thing to remember for asthma. And of course, because of your decreased caliber of your airway, you're going to have that shortness of breath, difficulty breathing. When the person's exerting themselves or even just walking, they're going to have a more difficult time getting enough airway and getting enough oxygen and air into their system to feel relaxed. And then again, you know, with asthma, it's recurring episodic symptoms. So it doesn't have to be constant. Somebody might not have symptoms all day and all night. They might say that they're feeling better at certain times of the day, but then feeling worse again, like mostly at night. And then triggers like exercise, cold air, allergen exposure, or viral infections might also cause an issue. And my computer is getting low on battery, just in case you guys totally lose me. And so, and a personal family history of allergic disease is also important to get when you're first seeing a patient with asthma. And so, but the important thing to remember also with asthma is there's many different types. So normally, or for a lot of people, asthma will present in childhood. Like I've had asthma ever since I was a very, very small child, and it continues into adulthood. But some people can get adult onset asthma. There's allergic asthma, which is mostly what we've been talking about. But then there's also an asthma COPD, which is chronic obstructive pulmonary disease overlap. Then there's only exercise-induced asthma, where someone will only have asthma when they're exercising. And then there's non-allergic asthma, where there isn't an allergic trigger causing their asthma, but they still have that irritation of their muscles and the inflammation irritation. And then there's occupational asthma, where people are exposed to chemicals and triggers. For example, the World Trade Center. After the World Trade Center, a lot of people had what we called occupational asthma from their exposures to all of the different chemicals and toxins and all of those things that were released during the World Trade Center collapse. And so, and then there's eosinophilic asthma, which is a new asthma that we've identified, where the person has high levels of eosinophils that cause inflammation and irritation in the airways. And so, again, the physical exam can be normal, but for somebody that's very severe, they also will not have a normal physical exam, or if they're currently in the middle of an asthma exacerbation, they would not have a normal physical exam. But again, you can have somebody that doesn't have controlled asthma that comes in with a normal physical exam at that particular moment. And so pulmonary function testing is very important in diagnosing asthma. And we do something called pre and post spirometry, which I'll talk about a little bit. And there's also bronchoprovocation testing, which honestly is only done in large hospital centers, but pulmonary function testing we can do in the office. And then peak expiratory flow monitoring. This is kind of not as in vogue as it was in the past. And so spirometry, you're going to see something called an obstructive pattern. So with spirometry, there's usually restrictive or obstructive. In asthma, it's an obstructive pattern where you're going to have a reduced, this particular ratio, which is your forced expiratory volume in the first second over your forced vital capacity. So essentially this, when you compare those two, that is going to be reduced like below 80%. And so that's when you know you have an obstructive pattern. And then your pre and post spirometry means that you look at, you have this person do spirometry. So spirometry is basically a test where you're having the person breathe into this machine, machine that measures all of these different numbers and looks at the airway, basically with computer monitoring. And you have the person do that exam before they use their albuterol, which is a medication that relaxes the smooth muscle, and then they do it after. And if you see a 12% change in their FEV1 or their forced expiratory volume in the first second, then you can, that's one of the ways that we diagnose asthma. So, but right now what's happening is that, we're not even using spirometry in the office because it's an aerosol generating procedure. And with COVID, there's a worry that you would expose the person that's doing the testing. If somebody was asymptomatic but had COVID and you're doing spirometry on them, they could actually release that COVID, the virus, into the environment and make, and put the healthcare providers at risk of getting COVID more easily. And so right now, most doctors are not doing spirometry in the office setting. I think it is being done in hospitals in very specific cases where it's very, very important to get this information. But right now, I think a lot of doctors are just using the history. And so, again, I'm really nervous. I think I'm gonna stop here. There's a way of classifying the asthma severity, and that's based on symptoms, the nighttime awakenings, how often you're using your rescue medication, and then the lung function exam findings, and then how often are you, having to use oral steroids. So there's like a whole way that we classify asthma, and that is a whole lecture on its own. But really quickly, because I've talked about rescue and controller medications a little bit, I just want to go into it before we stop, is that a rescue medication is something called a short-acting beta agonist, or albuterol. And essentially the rescue medication helps with that muscle getting tightened quickly. And it helps relieve the symptoms quickly. But you can't use albuterol constantly throughout the day, because we know that patients that are doing that for a whole number of reasons are at higher risk of death from asthma. And the reason for that could be that they have uncontrolled asthma, they're needing to use their albuterol, so they're at higher risk of death. But also we know that albuterol is a cardiac stimulator, so it stimulates your heart, and so over time that stimulation could lead to cardiac arrhythmias and could also lead to death. So using your albuterol too often is not recommended, and it's not meant to be used daily. And so that's a really important thing to know with asthmatic patients, because it helps, because the asthma medications, the short-acting asthma medications help so much. A lot of patients just constantly just want to use that because they just want to feel better. They want to be able to breathe. But the controller medications are really what's important, and they don't necessarily help somebody feel better right away. So that's why the compliance with the controller medications isn't as good. But so controller medications are for people that we know have that underlying inflammation. So not every asthmatic, so if, for example, for me, I have mild intermittent asthma. So my asthma only really reacts when I'm exposed to something or when I'm doing heavy exercise. So for me, I don't have, and so I would just use my short-acting medication. But for people that do have daily symptoms, have consistent symptoms, or even like greater than 2 times a week, that means that they have some inflammation in their airways, and so we would need to use a controller medication. So different controller medications are like inhaled steroids with a long-acting beta agonist. So long-acting beta agonist is another medication that's safe to be used every day and doesn't stimulate the heart as much. And that can be combined with a steroid, or something like a long-acting muscarinic agent, which is Spiriva, which we normally just use for COPD. But in the last 5 to 6 years, there's been studies that show that we can also use this medication as an add-on treatment for asthmatics. And then there's leukotriene receptor antagonist, which blocks the allergic reaction in a different way. So for allergic asthma patients, the montelukast, or this leukotriene receptor antagonist, is another medication that we use. And then over the last about 10 years, we have biologic treatments, which target antibodies, inflammatory molecules, or cell receptors for asthmatic patients, and especially for patients with eosinophilic asthma, for example, that disrupt the pathway that lead to the inflammation that causes asthma symptoms. So these are a huge game changer, especially for patients with really severe asthma. And then there's also something called bronchial thermoplasty, which is a way to essentially use radiofrequency to burn some of the excess tissue in the airways. But this is really like a last line therapy for patients that aren't responding to any of this, because obviously you can just tell that is a more invasive procedure. And so there are, you have to weigh the pros and cons of using that. So that's like a basic overview of this case. But again, asthma is a huge topic. There's so many things that you can discuss. And then quickly, other things that allergists treat: food allergies, something called eosinophilic esophagitis, urticaria, which is hives, eczema, which is allergic skin condition. And then we also treat immune deficiency disorders. So there's primary immune deficiencies, And then there's secondary immune deficiencies, but we mostly treat the primary immune deficiencies, which is where you're missing an enzyme, a cell type, non-functional component. And most of these are kind of congenital and manifest early in life. So these will mostly be seen by those academic allergists. But then also in my practice, I see something called common variable immune deficiency, which is something that can present later on in adulthood